Today we're going to be discussing electrolytes and the function that they have within the body. Electrolytes are active chemicals within body fluids that carry either positive or negative charges. Positive charged ions are known as cations, and negative charged ions are known as anions. Electrolytes are important to maintaining homeostasis within the body. Imbalances in these electrolytes can cause dysfunction in cardiac, neurologic, and respiratory functions, which may eventually lead to death. Sodium is a major cation within the extracellular fluid. Its expected reference range is between 135 to 145 milliequivalents per liter. Hyponatremia occurs when there's a serum sodium level of less than 135 milliequivalents per liter. Signs and symptoms include anorexia, nausea, vomiting, lethargy, dizziness, muscular twitching, cramping, or weakness, seizures, papilledema, dry skin, increased pulse, decreased blood pressure, weight gain, and edema. Nursing management of hyponatremia includes careful administration of sodium by mouth, NG tube, or via parenteral route. Restriction of fluid volume, hypertonic 3% sodium chloride, and AVP receptors such as IV convaptan hydrochloride or tolvaptan. As well, the nurse needs to identify and monitor patients at risk for hyponatremia. The nurse monitors the patient's INO and daily body weight. The nurse must monitor lab values and be aware of GI signs such as anorexia, nausea, vomiting, and abdominal cramping. For the patient that can consume a general diet, the nurse encourages the patient to eat foods and drink fluids with a high sodium content to control the hyponatremia. Examples of this include broth made with 1 beef cube or tomato juice. If the primary problem with hyponatremia is water retention, it is safer for the nurse to restrict fluid intake than to administer sodium to the patient. Hypernatremia occurs when there is a serum sodium concentration of greater than 145 milliequivalents per liter. Signs and symptoms include thirst, elevated body temperature, dry tongue and sticky mucous membranes, hallucinations, lethargy, restlessness, irritability, simple partial or tonic-clonic seizures, pulmonary edema, hyperreflexia, twitching, nausea, vomiting, anorexia, increased pulse, and increased blood pressure. For patients with hypernatremia, treatment consists of gradually lowering the serum sodium level by infusing hypotonic electrolyte solution. For example, 0.3% sodium chloride or an isotonic non-saline such as dextrose 5% in water. Demopressin acetate, which is a synthetic ADH, may be prescribed if diabetes insipidus is the cause of the hypernatremia. When parenteral fluids are necessary for managing hypernatremia, the nurse monitors the patient's response to fluids, reviews serum sodium levels, and monitors any changes in neurologic status. Potassium is a major cation within the cells. The expected reference range is 3.5 to 5 milliequivalents per liter. Hypokalemia occurs when the serum potassium concentration is less than 3.5 milliequivalents per liter. Signs and symptoms of hypokalemia include fatigue, anorexia, nausea, vomiting, muscle weakness, polyuria, decreased bowel motility, ventricular asystolia or fibrillation, paresthesia, leg cramps, decreased blood pressure, ileus, abdominal distension, and hypoactive reflexes. EKG changes that are to be expected include flattened T waves, prominent U waves, ST depression, and prolonged PR interval. If hypokalemia isn't able to be managed by increased intake of potassium within the diet or by oral potassium supplements, then it's treated cautiously with IV replacement. To correct severe hypokalemia through IV management, potassium chloride, potassium acetate, or potassium phosphate may be prescribed. Potassium should only be given via the IV route after adequate urine output has been established. The nurse needs to monitor the urine output during infusion of IV potassium. Potassium is never to be given by IV push or IM. It must be administered using an infusion pump. As well, when infusing IV potassium, the patient needs to be hooked up to continuous EKG monitoring. Through IV administration of potassium, the nurse monitors the patient for signs of worsening hypokalemia and hyperkalemia. The nurse educates the patient with hypokalemia about introducing foods and potassium into his or her diet, such as oranges, bananas, cantaloupe, prunes, squash, potatoes, and sweet potatoes. Hyperkalemia occurs when there is a serum potassium concentration greater than 5 milliequivalents per liter. Signs and symptoms include muscle weakness, tachycardia to bradycardia, dysrhythmias, flaccid paralysis, paresthesia, intestinal colic, cramps, abdominal distension, irritability, and anxiety. For the treatment of hyperkalemia, reduce foods or supplements that are high in potassium. For patients that have severe hyperkalemia, the nurse may need to administer IV calcium gluconate. The nurse monitors the blood pressure to detect hypotension, which can result from rapid IV administration of calcium gluconate. Also, during the infusion, the nurse monitors the EKG, and the appearance of bradycardia alerts the nurse to immediately stop the infusion. To treat patients with less severe hyperkalemia, there needs to be a restriction of dietary potassium and potassium-containing medications, such as eliminating potassium-containing salt substitutes or stopping potassium-sparing diuretics, such as spironolactone. The patient may be treated orally or by retention enema with Electrolyte to decrease serum potassium levels. As well, administering 50% glucose with insulin IV is indicated in the treatment of hyperkalemia. There are some other important expected reference ranges that we should know, such as magnesium's expected reference range is 1.3 to 2.3 milligrams per deciliter. Calcium's expected reference range is 8.6 to 10.2 milligrams per deciliter. Chloride's expected reference level is 95 to 105 milliequivalents per liter. And phosphorus's expected reference level is 2.5 to 4.5 milligrams per deciliter. Hypomagnesemia occurs when the serum magnesium concentration is less than 1.3 milligrams per deciliter. Signs and symptoms include neuromuscular irritability, positive Trousseau and Chbostik sign, insomnia, mood changes, anorexia, vomiting, increased tendon reflexes, and increased blood pressure. EKG changes that are noted included PVCs, flat or inverted T waves, depressed ST segment, prolonged PR interval, and widened QRS complex. The nurse educates the patient with hypomagnesemia about sources of magnesium-rich foods that should be included in his or her diet, such as green vegetables, nuts, legumes, bananas, and oranges. Patients with mild hypomagnesemia can be treated by adding magnesium-rich foods to his or her diet. Overt symptoms of magnesemia are treated with IV administration of magnesium. A bolus dose of magnesium sulfate that is given too rapidly can produce alterations in cardiac conduction and lead to heart block or asystole. The nurse should monitor vital signs frequently during magnesium administration to detect any changes in the cardiac rate or rhythm, hypotension, and respiratory distress. Hypermagnesemia occurs when there is a serum concentration of magnesium greater than 2.3 milligrams per deciliter. Signs and symptoms of hypermagnesemia include flushing, hypotension, muscle weakness, drowsiness, hypoactive reflexes, depressed respirations, cardiac arrest, coma, and diaphoresis. ECG changes that are noted include tachycardia to bradycardia, prolonged PR interval and QRS, and peak T waves. In patients that have severe hypermagnesemia, all parenteral and oral magnesium salts are discontinued. In emergencies such as respiratory depression or defective cardiac conduction ventilatory support, IV calcium gluconate is indicated. Administering loop diuretics and sodium chloride or lactated ringer IV solution helps magnesium excretion in patients that have normal renal function. The nurse caring for a patient with hypermagnesemia monitors the patient's vital signs, noting hypotension and shallow respirations. There are specific labs that can be used to identify fluid volume deficit. These include the Bunn to serum creatinine ratio, the hematocrit level, serum electrolyte levels such as potassium and sodium, urine-specific gravity, and urine osmolality. There's one last question that needs to be answered before we let you go. If you answered that the nurse should monitor for hypokalemia and hyponatremia, then you're correct. Thanks for tuning in.